Hey there, future nurses. If you are getting ready for the NCLEX, you know that nailing the fundamentals is absolutely everything. So in this explainer, we are going to tackle two of the most important areas, vital signs and key lab values. We'll break down the numbers you just have to know, and then we'll see how they play out in a real-world clinical scenario. Let's jump right in. Okay, let's start with a question that really gets to the heart of nursing judgment. Picture this on your exam or even on the floor during your first week. Your patient's condition is heading south fast. All the data is right there on the monitor, so what do you do first? Knowing the answer to this is what really sets great nurses apart, and we're going to walk through it step by step. So here's our patient. They're fresh from the PACU, the post-anesthesia care unit. Take a look at their baseline vitals when they first hit the floor. Now look at what happens just half an hour later. You see that? A massive drop in blood pressure, a huge spike in their heart rate, and their O2 sat is starting to trend down. This is a classic NCLEX-style question designed to test one thing. Can you spot a critical change and act on it? The key to solving this is really understanding what these numbers are screaming at you. Now, before we can solve the puzzle, we have to understand the pieces. And in nursing, the most basic clues we have are the vital signs. So this first section is all about locking in those core numbers and getting what they tell us about how well our patient's body is getting the oxygen it needs. First up, temperature. You have to know this range, 36.4 to 37.5 degrees Celsius. It's a foundational number. Now, our patient's temp was okay, but you have to remember, a post-op fever can be a major sign of infection, while a drop in temperature can point to other serious problems. Go ahead and burn this range into your memory. Next is the pulse. The normal range for an adult is 60 to 100 beats per minute. But you know, it's so much more than just a number. Clinically, we use the pulse to see how a patient is tolerating things. Think about it. When you get a post-op patient out of bed for the first time, how does their heart rate respond? That change tells you a whole story about how their body's coping with the stress. And beyond just the rate, a pulse has a quality, a strength that we grade. A normal, easy-to-find pulse is what we call a 2+. But a weak, thready pulse, a 1+, that could be a huge red flag for something like decreased cardiac output. On the flip side, a 4+ bounding pulse might make you think about fluid overload. See? It's all critical data. All right, let's talk respirations. The normal adult rate is 12 to 20 breaths per minute. Now here's a great tip for the NCLEX. A lot of the things that affect the pulse rate, like stress or exercise, will also affect the respiratory rate. It makes sense, right? The heart and lungs are working together constantly. And here's the why behind it. Our breathing is really driven by our blood chemistry. If carbon dioxide gets too high or oxygen gets too low, the brain tells the lungs, hey, breathe faster, fix this. But on the other hand, something like a head injury can actually shut down that respiratory center in the brain, causing breathing to become dangerously slow. It's all cause and effect. And now for blood pressure. A normal reading is less than 120 over less than 80. This is probably our single best snapshot of tissue perfusion. You know, is the body actually getting the oxygenated blood it needs to stay alive? This number is so important, especially in our post-op patient. And speaking of low blood pressure, let's make sure we define a term you will definitely see on the exam, orthostatic hypotension. Basically, this is when a patient's blood pressure just tanks when they go from lying down to sitting or standing up. Any patient who is dehydrated or lost blood is at a super high risk for this. Okay, so vitals give us one part of the story. It's like looking at the outside of a car. To really know what's happening with the engine, you've got to look under the hood, and that's where the lab results come in. These numbers can give us huge clues about bleeding, infection, and how well the organs are working. Let's kick things off with coagulation studies. For any patient right out of surgery, bleeding is a top concern. We use tests like APT, PT, and INR to see how fast their blood is clotting. And those therapeutic ranges you see there, those are the target numbers for patients who are intentionally on blood thinners. Okay, listen up, because this is a classic NCLEX question. You absolutely, positively have to know which test goes with which medication. APTT monitors heparin. PT and its buddy, the INR, monitor warfarin. Got it? Say it again. APT for heparin, PT/INR for warfarin. You have to know this. The complete blood count, or CBC, gives us a fantastic, broad overview of a patient's health. For our situation, we're really interested in two things here. Platelets, which are the little guys that help us clot, normally between 150,000 and 400,000. And white blood cells are infection fighters, which should be between 5,000 and 10,000. This is a massive safety alert. If you ever see a lab report with a low platelet count, that's called thrombocytopenia, your brain should immediately scream bleeding precautions. This is an immediate nursing action. It means things like using a soft bristle toothbrush, avoiding any unnecessary sticks, and watching them like a hawk for any sign of bleeding. It's a direct line from a lab value to what you have to do. And finally, let's quickly review a few key chemistry labs. Potassium is a huge deal for the heart, and notice how tiny that normal range is, 3.5 to 5.0. Small changes can cause big problems. For the kidneys, we look at BUN and creatinine. Just remember, the serum creatinine is the most specific, most reliable indicator of how well those kidneys are filtering. All right, we've reviewed the tools in our toolbox. We know the normal ranges for vitals and labs. So now, it's time to put on our detective hats, get back to our patient, and figure out exactly what is going on here. So just to recap, here's where we started when the patient first arrived. This is our baseline. This is ground zero. Everything that comes next gets compared back to these numbers. The BP is a little high, heart rate is kind of up there, but all in all, this is a pretty stable starting point. And then, look at this. A half hour later, everything has changed. The blood pressure has completely tanked to 95/54. That's hypotension. And what does the body do in response? It tries to compensate. The heart rate shoots up to 118. That's tachycardia. The body is trying desperately to pump what little volume it has around faster. This combination, along with that dipping O2 sat, is a huge, undeniable red flag that this patient is going downhill. Okay, so you've correctly identified the problem. The patient is unstable. Now comes the most important part of all. What do you, the nurse, actually do about it? Let's walk through the prioritized actions. Here's your game plan in the right order. First, you compare to the baseline to confirm this change is real and significant. Second, you do a super quick check of your equipment. Is the blood pressure cuff the right size? Is it on correctly? Third, you do a quick mental check of their history. But here's the most critical step for this patient. You must immediately physically assess for bleeding. Get your eyes and hands on that surgical dressing. Look at the output in any drains. Check for swelling. As soon as you've done that, you get on the phone to the surgeon. And finally, you always keep your charge nurse in the loop. We've solved the immediate problem, which is great. But the real learning here comes from pulling back and understanding the principles behind our actions. So let's wrap up with the key takeaways from this whole scenario. Remember these rules to live by for safe nursing practice. First, always have a baseline. Without it, you can't know if a change is significant. Second, look for trends. One set of vitals is just a snapshot. The change over 30 minutes told the real story. Third, and this is a big one, you can delegate the task of taking vitals, but you can never, ever delegate the responsibility of interpreting them. That is 100% on you, the nurse. And finally, when you see a significant change, you have to act. Don't wait. Let's end with one last question to keep those critical thinking gears turning. You've made the call, the surgeon is aware and on the way. But what can you do for this patient right now? What's an independent nursing action, something you don't need a doctor's order for, that could help support their blood pressure while you wait? That next level thinking is what makes a truly great nurse. Thanks for joining me, and keep studying smart.